has to be so much a part of our conversation, because that eats at you physically. And then that causes more health conditions down the road, the kinds of traditional conditions that we think about. So I worry about that. I also worry about the issue of social determinants of care. I think the issue of whether families can afford food and have the access they need. And there are many issues in that category of social determinants. And then the digital divide, which I know Mr. Chairman, you spoke about in terms of what the legislature is doing, and it's such an important priority because digitization is going to play a major role in healthcare. But it's really got to go back to, we want the primary care physicians to have the support that they need to be the folks on the other end of that screen dealing with their patients so that they can provide that continuity of care. So it comes back to primary care, investing in the physicians who are in the community to really make sure we're dealing with isolation, the digital divide, vaccine hesitancy, et cetera. People who look like the community, who are respected by the community, who are embedded in the communities they serve.
And I want to echo your point, Karen, and of course, Dr. Tallaj too, on these access challenges. My goodness, on food, our challenge for the last year has just been getting people who are food insecure a meal. I fear that we have lost focus on the healthfulness of that diet, and that we're going to have to redouble our efforts on that front, because access to affordable, healthy food is directly connected to all the leading risk factors for COVID and so many other health complications. And it's just true that in low-income neighborhoods, healthy food is not as accessible or affordable as it should be. But just a word on the affordability and accessibility of healthcare more broadly. You know, there are still hundreds of thousands of people in New York City who do not have health insurance, and most of them are adults who are undocumented. Not exclusively, there are other people who, for various reasons, haven't been able to access. And while it is true that they can receive care regardless of status or ability to pay it in emergency rooms and other health providers, that's undoubtedly true, thank goodness. It's also true that that happens generally when people are in crisis, and that folks who don't have health insurance get much less primary care, much less preventative care, much less early diagnosis, much less vaccination, talking about in general, not just COVID, with horrible health outcomes. It's one of the reasons why we need to get everyone into health insurance, regardless of their documentation status. The plan the city has put forward, NYC Care, which probably most of you are familiar with, is designed to help bring people without insurance, primarily undocumented, into healthcare, into primary care, to have a relationship, to have a card that shows they belong to the program with a doctor that will be their main contact, a customer service number, all of that, modeled on what was done in San Francisco and Los Angeles along these lines. But the program so far only works in H&H facilities, in hospitals and clinics run by Health and Hospitals. And that just leaves a gaping gap, a huge gap. There are many communities where there's no H&H facility. There's no H&H facility in, I don't know, Sunset Park, Brooklyn, or Flushing, Queens, large immigrant communities with huge needs. And so we're working on legislation in the council that would require FQHCs and potentially even family doctors to be part of this program, so that people without insurance can have a primary care home to have the kind of annual physicals to catch problems early that will ultimately save our city money, will save hospitals money, will save H&H money. There is much more work to do for true access to primary care for people who do not have insurance in the city.
You know, I think a key issue that we need to remember is for a couple of generations now, healthcare has been evolving from where doctors were primarily individual practitioners or maybe part of a small group practice to where they became part of larger and larger practices. Those practices became affiliated with hospitals, if not actually being owned by hospitals. Now we've got insurance companies partnering or being co-owners with CVS, which in turn is putting clinics in its stores. So you're going to see a doctor who is not only owned by the drugstore, but in turn owned by an insurance company. This kind of corporatization and industrialization of healthcare, I profoundly believe is not good for people who want to practice medicine or nursing or anything else, and certainly not good for patients. And there's no way to turn the clock back, but we can turn the clock forward from corporatization to democracy. And the way to do that is to take the payer element and take that out of the corporate sector and make it a publicly run, publicly accountable, universally available system. If we want doctors to not be the paid servants of our insurance company, we've got to do something dramatic to change that.
You know, I'm always interested when we talk about, you know, how more resources should go to primary care, but you know, when we have to rebalance the healthcare system, but then everyone's worried about, oh, is there enough money and can we do this? But what we know is that even one additional primary care provider per 10,000 people, which is kind of the metric that we use, can yield over 5% fewer hospital visits, right? That's how you pay for it. You rebalance it by putting your money up front into prevention and into primary care, and then you don't need that money at the end. But the way that we've done it, it's very perverse. We basically said, oh, you have to show me first that you can save all the money before I'm gonna resource primary care. And that is sort of the continuous conundrum of our system, which is that, you know, primary care is asked to prove its worth over and over again. Where, you know, you don't get that kind of a question of proof from, say, the cancer doctors. You don't get that kind of proof from the dermatologists. You don't, you know, show us the proof before we're going to allow you to do this work. We don't require that kind of proof of certification of more and more high-end hospital procedures in this state. But we really require a lot of primary care. And not only that, we require it in a way that says, well, you do all these services and maybe in a year, you know, we'll pay you for what you did last year. And we're going to tell you what your gaps in care were, so that, but, you know, and how much money you didn't make this quarter. And, you know, maybe next time you'll do that, you know, pick that money up. But it's very hard for primary care providers to sort of put in the resources necessary without that upfront investment. And I think that's one of the things that my hope is that we will come out of this pandemic and really think about that primary care investment piece up front. You know, primary care, I've said this before, I'll say it again, it gets about 5 to 7 cents on the healthcare dollar. In a lot of states, they're looking to get primary care up to 12 to 14 cents on the healthcare dollar. It's what they spend in those countries that we think have the best healthcare system. And so, you know, I think it's not always about the money, but it is about the investment. And I think that's really, really important. And one of the conversations that we just have to have in this country, you know, I was reading Modern Healthcare this morning. Just in this last quarter, venture capital put over $10 billion into healthcare firms, startups in this quarter. So I'm thinking that if there's $10 billion that we can have in the system, you know, to shore up primary care, wouldn't that be amazing? And wouldn't that be something worthwhile investing in? And I think that's a really big question for our society. You know, where do we want to invest our money? And I'm kind of arguing that we want to invest it upfront in the primary care system, as well as in the public health system, the behavioral health system, those things kind of all in my mind. for sort of form a trio of required things that we really need.
And what you and Dr. Tallaj are saying is that in
what you said briefly, the state is paying $8.2 billion in a program called District that actually was so told to us at the beginning it was only for hospital, how to decrease admissions, ER visits, put everybody in computers, talk each other, have same protocols. We one of them, Somos is one of them, it was 25 then. 24 were hospital-based, one was physician-based. We saved just in 2018, 336 million in our patient, equivalent 11.9% for each patient per member per month. And health in Medicaid patients, decreasing 36% ER visit, 39% admissions. It's possible. It's possible. But that was part of his payment. But what happened between now and then? You change directors and the people who are supposed to continue this. You don't push into that to happen. And thanks to Karen, who's here, she signed with us what we call innovation contract because they believe in this. But if nobody's on the political side looking after that, and the people who made the lobby want to destroy the institution who create this, it won't happen. I will make a twist on what the Gottfried said. I'm willing to work with you on that. But I believe a lot of group of doctors like us, we could take that also and work with you and give you a saving in whatever money you've been paying, being spent it, and show you that we could split that the way the ACO. We were number one ACO for 5 years in the state of New York, number 9 in the country, saving around 150 million with the last 4 years to the federal government. But you put in hand people who could do the job, and that's what we did. And at the same time, getting quality, and saving money, and compliance with what your specification were.
I wanted to bridge back, Dr. Tallaj, where you've just left off to Mark's point about the legislation, Mark, that you're looking at in the council. I think there is a propitious time to think more broadly about how you distribute the resources, not to take it away from anyone, as Dr. Tallaj is saying, but to invest in physician practices that are embedded in the community. I think you'd get quite a return, and it would, these are the physicians that have been there through the pandemic. So again, not to crowd anybody else out, but to include them as part of the potential program, number one. Number two, Dr. Tallaj, you remind me that we're coming up to District 2.0. There'll be a lot of discussion. There's a real opportunity to reset and invest in primary care. And I think hopefully all of us can be involved in those conversations to really take the learnings, unfortunately, how horrific it's been in this pandemic, and say, how do we plant the flowers to make this city and state stronger going forward? And I think there's a recipe for that.
I think that with that, that's pretty much the time that we have, but thank you all for this discussion today. This has been really great. And thank you everyone for attending this panel.
Thanks,
Thank
everyone.
you. Thank you.
And thank you, Maya, and thanks again to all of our panelists for once again a very good discussion. I'm going to just keep on moving things along. Hopefully, all of our panelists for the next one are on here and ready to go. Because next time we're going to be talking about innovative health programs and services in New York. We have a lot of panelists that can discuss some innovative new ideas they have for the changing sector. And most of all, we have moderating Sabrina Shulman, a senior consultant for Brown & Weintraub, one of our sponsors. And with that, I will hand it over to Sabrina to lead the panel. Thank you.
Thank you all. I am excited to be having this conversation with you all this afternoon. The COVID-19 pandemic has tested New York's health systems and services in a way that most of us have never seen in our lifetime. Everyone from government, healthcare providers, private companies had to turn on a dime to meet the moment. And while we saw some critical system failures, crisis is also the mother of invention and can be the launchpad for greater creativity. The 6 panelists that you're about to hear from have deep experience developing and implementing innovative strategies, both for tackling the current pandemic, but also to take on larger public health issues. So we only have about 55 minutes and we've got lots of folks to share their ideas. So I am going to jump right in. Just some housekeeping. I'm going to start with one question to the whole group that all of the panelists are going to be invited to chime in on. And then I'm going to direct some specific questions to each panelist that others will feel free to add to once they've had a chance to respond. But to get things kicked off, the COVID-19 pandemic, out of necessity, became a catalyst for healthcare innovation. How do you see the technologies, new care models, and outreach strategies developed over the past year transforming healthcare delivery as we move into a post-pandemic New York? First, brave soul.
Yeah, sure. This is Cherry Drulis. I am the healthcare director for the East region at T-Mobile. So I'll bring a little different perspective, more from a carrier response to the question. We all are fully aware of the challenging times that we've been living in and how it has reconstructed our lives, but most importantly, how we are delivering healthcare today. Everything was shut down. We found ourselves living in our homes, experiencing a lockdown, which accelerated the digital transformation in our healthcare delivery model. That caused the rapid growth that we're currently seeing and talking about today throughout the various panels that we're seeing in the industry, leading to healthcare facilities rapidly implementing technology to deliver medical care to our patients. And not only trying to deliver medical care, but trying to address that digital divide and social determinants of health to ensure that, all of our patients were receiving adequate health care. In my opinion, I think these trends are going to continue well into the next decade. That means that we're going to have to look at new technology. We're going to have to embrace digital care delivery models that can support more remote patient monitoring, telehealth platforms, and also consider moving some of those therapeutic interventions out of the traditional brick and mortar hospital setting into more of the outpatient setting, into those lower cost settings, where it's technically and economically feasible, of course. But, that also increases the reliance on electronic communication between clinicians and patients that is reliable on a true network that's strong, right? How can we provide that care to all patients regardless of location? So moving forward, I envision that we will be embracing a new hybrid approach to healthcare. So seeing more of that telehealth delivery model that supports, like I said, the remote click and mortar and transitioning away from brick and mortar to ensure that we're providing care to our patients and finding new ways to address that social determinants and digital divide.
Maybe I can add something to that. I think it's important to acknowledge that not much innovation was created around these ideas during the pandemic. It was used more extensively than it's ever been used before. But I think if anything, we need to look pretty long and hard at why we were so complacent looking at a lot of these telemedicine technologies, remote monitoring as kind of proof of concepts and hobbies that people were pursuing. And then all of a sudden, we wound up in this situation where one of the underlying assumptions, even in an outpatient setting, that the caregiver and the patient can be in the same room at the same time, turned out to be a foundation that was ripped out from underneath us. And so I think, I don't want to say it in a positive way, but the lockdown became a catalyst to take some of these things that were simmering on the back of our healthcare clinical trial fringe technology ideas and turn them into this necessary digital transformation. And so I agree. I don't think there's any putting that genie back in the bottle, and probably in a good way. And I think one of the really interesting questions and challenges is how do we now kind of shift our mindset and figure out how to leverage these things much more intensely, much more fully as we move forward into whatever this new world we're creating is.
And if I could jump in, my name is Ted Long. I'm a primary care doctor. I'm the executive director of the New York City Test and Trace Score, and I'm the senior vice president for ambulatory care and population health at New York City Health and Hospitals. And I think what you said really resonated with me is I, as a primary care doctor, did a couple telephone visits before COVID. Now in our ambulatory system, we've done more than 1.2 million telehealth visits. So going from 0 to 1.2 million was a pretty fast pace. The technology did exist before, you're totally right, but we really ramped up, and there is no going back. There's no putting the genie back in the bottle. But I think beyond that too, one of the questions I ask myself is, what have we learned with the transition to telehealth? And for me, part of it is meeting people where they are. This is something that people find valuable. And on the test and trace score side, we early on invested heavily on what we thought would be a value in terms of not making people come to us to get tested, but bringing testing to your doorstep. So we have 40 mobile units that we created. Again, mobile units existed, but not at this scale before. Drive around the city every day today doing rapid COVID tests. We have 20 mobile vaccine units to drive around, set up different stations, and deliver the vaccine to you in a variety of settings now. These are things that could have been done before, but are being done now, and not just being done at scale. And I think part of what the future in my mind looks like is these things represent the principle of patient engagement, unprecedented patient engagement. And one of the things that I want to see us do on the primary care side is really think about the different dimensions of this too. So I want to engage our patients that are homeless too. We have a special clinic for people that are homeless in New York City Health and Hospitals. How do we have community health workers that go out there and pull them into our clinic? And then what does mobile health care look like for homeless people moving forward? Same thing with people leaving jail. Same thing for families in the preventive services part of our system, or kids in foster care. And I think there's so much patient engagement we can do that's not just bringing care to your doorstep, but includes telehealth and includes really meeting you where you are, and us on the healthcare side thinking beyond the four walls of our office. And whatever it is of value to you in the context of your life, having us deliver that to you. And I think that's what the future looks like for me.
Yeah. If I may have a slightly different perspective to the people here, where we have, if one thinks 14 months ago, the idea that an individual would have to communicate personal health information or personal health status to a non-professional, to a third party, maybe at the door of a football stadium or a restaurant, would have been beyond comprehension. And now it's being looked at as being acceptable, almost expected. And what we've had to develop in that time is, how do you actually interface private health information or private health status in a public environment? We're working with, in EasyTru, partnered with HealthX, the Health Information Exchange. And we work with over 2,000 organizations across the New York State, holding 8,000 facilities, and currently hold real data for 20 million New Yorkers today. And what we're looking at is, how do those New Yorkers access that data in a mobile scenario to allow them to get back to normality while respecting their privacy, and also allowing business to work with that data without incurring privacy issues themselves. So I think that is actually, if one looks at how we've come from 14 months ago to today, it's a huge change. And that's something that's happened over, as I said, over the last 14 months. So that is a huge change from what we're seeing today also.
Yeah, and I would just add, I want to say, great minds think alike, because as I was thinking about healthcare innovation, everything that my panelists have said so far, I've thought about whether it's been telemedicine or bringing healthcare to the patient. I think some other innovations that we've seen, the pharmaceutical innovation, I think it's simply amazing that we've seen the ability of the pharmaceutical industry to bring drugs from bench to market in under a year, where normally on average it would take over 12 years. I also think another innovation that I've seen that I've been amazed with is the ability of healthcare providers, bricks and mortar, their ability to grow and expand and contract based upon community need and and patient acuity. And I think, that's something that we'll most likely see after COVID as well.
Hello, my name is Maryanne Schretzman. I'm the Executive Director of CIDI, which is the Center of Innovation through Data Intelligence for Health and Human Services here at the Mayor's Office. And we've seen unprecedented change. And I wasn't sure if Dr. Ted Long was going to mention some of the work of what has gone on in health and hospitals just around the Bridge program and working with folks with opioid issues where we've been able to do some teleconferencing and also get medical assisted treatment to them. This is pretty amazing because some of the issues for many of our folks from, if you talk about from my side of the ledger is really on human services, is the engagement and outreach are so important, and engagement and outreach are often crucial for our folks to get involved. And how do we do that? And we often know how to treat, but it's that engagement. And we've found that the teleconferencing has really made a difference for so many people. And that's just one example, but we have so many other examples. I think too, just another one of yours, Dr. Ted Long, is your test and trace program, where you provided a cash transfer, which was folks who received $1,000. And when we think of social determinants, jobs and income, the biggest determinant of social determinants is income. And to be able to give people money during a tough time is really an important innovation and something that we will be testing to see how it mattered. But other kinds of innovations sometimes are around processes that have really made a big difference. And speaking about the homeless folks, many times to get the different kinds of housing and to match needs with services, there needs to be a psychiatrist or a professional to fill out these applications, and just getting folks to appointments and setting this up can take an enormous amount of time, where with some of the technology that we've been able to use has expedited appointments, expedited assessment, and really got treatment quickly, and also matching needs with housing appointments and assistance and the right type of housing has really made a difference during this time. So I think some of those transformations will be with us, and we'll be building on those transformations as best practices.
Well, since you name checked him a couple of times, I'm going to start with a specific question to Dr. Ted Long. We all, well, I'll speak for those of us who live in New York City. Anyway, we heard a lot, test and trace, test and trace, test and trace. This has been a mantra we've heard for the last year plus. And I think many of us have sort of an inkling of what it meant during the pandemic, but I think many of us have been reading about some of the evolution of that program and how you're using what you've learned to look to the future and evolve. So could you give us a little bit more of a peek into what test and trace really meant over the last year? And also, what does the future look like for test and trace, and how are you using that knowledge to tackle new problems?
Yeah, well, thank you. And that's a great question. So, looking back March and April of last year, New York City was the epicenter of the COVID pandemic in the United States of America. And I remember, going to the front lines in our hospitals, seeing what it looks like to quadruple the size of our ICUs. And I told myself at that time, we will never go back to that. And it was one of the hardest times in my life. And I think, everybody experienced loss during that time. And I think we all had the resolution coming out of that New York City would stand together and we would do everything in our power to not go back. We went from being in that moment, that critical moment, to actually then going into the summer. We started test and trace in May, June of last year. And we were able to actually squeeze down the virus in arguably the hardest city to control it in the United States of America. We all live close together, multi-generation homes, major international airport. But we achieved pretty much the best control for months right here in New York City. And some factors that contributed to that were the degree to which we were testing, which on a per capita basis has been more than almost every other country in the whole world, with the exception of some of the smaller European countries like Luxembourg, which when we can go on vacation again, looks great. And also our contact tracing. You know, we invested heavily in contact tracing from the beginning. The goal of contact tracing this last summer was to suppress the virus, and I really think we did. But we did it a little bit differently here in New York than in other places. And I think it's maybe some of what you've heard about the program is we had a couple principles going into it. Number one, we said New Yorkers trust New Yorkers. So we're going to focus on building that trust. So we hired locally. The majority of our contact tracers are from our hardest hit communities. So the same people that experienced loss back in March and April are now talking to you on the phone. You're talking to somebody from your community. You're talking to somebody that you're going to trust. And I think that's been honestly the secret ingredient to the success of our program is our tracers, who are New Yorkers that are able to get trust, able to earn trust from other New Yorkers. The other thing is we in New York City like to move fast. And about our test and trace core, some of the unique things we did is we invested heavily early on. This is what I was responding to Glen about earlier, in terms of investing in a mobile fleet. Back when it was sort of being conceptualized, we went all in. And we've had 40 mobile units all with rapid testing capability for months. And that's something that we knew would be very important. And then we went a step further than that too, is we said, okay, well, what are we doing with people with positive tests? Instead of waiting to call them on the phone, which is the mainstay of contact tracing, we said, hey, in New York City, let's go even faster. Let's develop a new model called accelerated contact tracing. So if you come to one of my sites, you test positive on a rapid test, boom. In person there's a contact tracer that's going to perform contact tracing on you 15 minutes after your positive result. Then we're going to call your contacts or people that could have been exposed, bring them in for testing that day and break the chain of transmission that day. That speed. Also in New York City, as we're not patient, we knew early on that we'd be affected by the rest of the country in terms of turnaround time for labs. As places like Texas set more tests off, that has implications on the ability for New York City to use those same labs to create to have a good turnaround time. So we said, hey, we're New York, we're innovative. We know what we'll do. We'll create our own lab. So we did that. We actually created our own lab. So we've had control over our lab turnaround time. Again, for months now. Our median turnaround time for the PCR test, the gold standard in New York City, 1 day. It's been like that for months. So moving fast, I think, has been something really, really important to having the program succeed and achieving suppression this last summer. And I'll talk a little more about what we're doing now in a second. The other really unique thing about New York, which I think you may have heard about, and if you've ever been called by a contact tracer, you've been offered this, is the conversation doesn't stop at you have COVID. The conversation is you have COVID, and here are the 25 things we're going to do to help you. We're going to offer to drive you for free to our hotel, free stay, free meals, free medical monitoring program the entire time you're there. If you want to stay at home, free food delivery for you. We listen, and we I smile a little bit when I say this, but we got some feedback that people were saying, well, I have to leave my home, I have to walk my dog. Totally reasonable. I'm a dog lover, dog owner. My dog is very close to me right now. We said, well, if that's what it's going to take for you to stay at home, we will for free walk your dog for you. And that is true today. We will walk your dog for you for free. That level of support in New York City, combined with the trust that we built by having this be a program by New Yorkers for New Yorkers, predominantly from the hardest hit communities across our city, that's what it took to enable us to help New Yorkers to stay at home, give us contact, and break those chains of transmission. Now we've been on the tail end of our second wave. In the second wave, the goal is not to suppress the virus. You can't suppress it because it's in the community. But our goal was, can we diminish it through testing and contact tracing? And can we delay it? Every day we buy time is a day where lives are saved. And if we can diminish it, not have it skyrocket like it did in other places, that's lives saved too. If you look at our data, going into our second wave, the national second or third wave, depending on your location, we for sure had a delayed onset of that wave. And every day we were able to hold the line and delay the virus from taking hold in our city. This is back this last December, lives were saved. We also had a diminished peak of it. Compared New York City to the 5 largest states in the country, we're far and away had the lowest peak of new cases through the whole second wave. That lower peak translated into saved lives and translated into us having a lower per capita death rate than the rest of the country. So moving forward, we're now fully emerging from our second wave. The vaccine is taking hold. The numbers are looking better and better every day. But we're not out of the woods yet, and we have to keep our guard up. You can count on us doing full force contact tracing, full force testing. And then this next summer, what I expect is that we in the testing and contact tracing realm are going to be looking across the city, hand in hand with the Department of Health, best Department of Health in the whole world, in my opinion, fact. We're going to be looking for outbreaks. And when there is an outbreak, we're going to coalesce all of our resources together, the 40 mobile testing units, the 20 mobile vaccine units. We will descend on the communities that are having outbreaks, bringing everything we have to bear. We're going to control each outbreak, and that's what's going to get our city through. The final thing I'll just say briefly is, you know, we've learned so much over this last year, and I agree with everything that's been said in the panel so far. And I think the question for us now is, how can we leverage this, everything we've learned, to really create this future being a different and better place? And I'll say definitively, we're going to use telehealth, we're going to use mobile health, and we're going to use all of those principles and lessons for, you know, as Maryanne said, how do you create that engagement for different populations, especially the most vulnerable New Yorkers, and bring them into the fold for making sure everybody has access to primary care and that we're reaching you in the way that makes sense for you in the context of your life. We've learned a ton from COVID about what that means, the context of your life, from you know, the example of the cash assistance program we created, but we really listened, we were responsive, and everything we did there, we'll be applying full force to primary care to create a much, much brighter future for primary care moving forward. And I'm excited about that.
Thank you for that. So to springboard off, you know, the idea of government transitioning, you know, in the time of crisis on a programmatic level, I want to talk about government transitioning on a policy level. Liz, if I could, you know, pose the next question to you. You know, our government at the city, but particularly at the state level in New York, had to act quickly and transition when it came to healthcare regulation, and certainly around telehealth over the last year. And I wonder if you could share with us, you know, in your opinion, you've been deep in this for years in various roles, and what are the most important recent advances in telehealth? And, you know, what do you see are the current challenges and potential solutions to further advancing telehealth and the use of it in New York?
Yeah, thanks, Sabrina. It's a great question. And, you know, I think all throughout the panel today, as well as the previous two panels, you know, the importance of accessing telehealth and making, you know, telehealth and telemedicine available to all New Yorkers is really paramount. I think, you know, prior to COVID, it was really a niche industry where there weren't a lot of utilizers with telehealth and telemedicine. It was really commercial payers, and it was used in very rare instances. I will say the good news, this budget did allow for additional flexibilities in telehealth. We removed the requirements for the originating and distant site. Additional professions are now allowed to use and access telehealth and telemedicine. So I think those are really important advances. There were also changes to broadband, as well as affordability of broadband, which is, you know, a really key piece for everyone in the state of New York to be able to access telehealth and telemedicine. Some advances and flexibilities didn't make it this time around, including connectivity to the Shiny, as well as disclosures by both payers and providers to disclose whether they utilize and or pay for telehealth. You know, my hope is we will see those changes next budget around, because, you know, I do think that this is one modality we'll continue to see grow past pandemic.
Thank you for that. You know, to your point, telehealth has, you know, kind of exploded out of necessity over the last year. And I think a number of you have made the point that it is not only here to stay, but I think we'll continue to see expansion and innovation into different areas. And that bumps up against some other hot topics right now. And Brian, I'm going to pose the next question to you. As more and more healthcare is being delivered in this virtual world through apps and web-based platforms, how do you effectively manage data security? How do you inspire consumer confidence about sharing personal and medical information? Maybe not just with those companies, but to your point, more in a more public way because of COVID. How do you keep using data and innovating in a way that makes consumers feel confident about it?
Well, it really depends on the environment, who you're speaking to. Listening to Liz there. I mean, most of the environments here, we're talking to professionals, and it's a well-trodden path, and they know what to do with the data. The question is, how do you deal with the uninitiated? Now, as I said, we're working with HealthX, which is, or leveraging the huge investment by the state in health information exchanges. Cures Act has just come on board to give patients more access and use that data. So how do you do it? Our focus really has been, and we have this app, How to Verify Your Status, is that really what you do is the first step is you have to make sure that the person who's presenting the data is the person, i.e. there has to be proper identity protocols on the front to NIST 800 standards. Really, now that's available, and we have that obviously. And then, of course, in referring to HealthX, that the data they're using is real data and the person presenting it owns it. So that has to be done. But then the bit in the middle is, how do you allow the individual to use that? Now, in our experience, and we're canvassing users and on both ends. So the individual says, I want to confirm some aspect of my health record, right? What they don't want is, they don't want the person they're presenting it to having to inspect, because they're a non-professional and they're really not interested in it. What they simply want to know is, what action can I take on the basis of the data that's there? Now, in that sense, it really is, it's a query, yes, no. Can I let this person into my facility, right? I don't want to look at their health records. I want to be able to say, look at them, query their an app, or the EasyTru app, and essentially be told, can I let this person into my facility based on the criteria which I have? They don't want to access your data. They don't want to keep it. They just want a yes, no. Equally, as the individual, you don't want to be exposing your private medical data. This is available today. As I said, there are 20 million New Yorkers whose vaccine COVID data is available and held on HealthX and available through this platform. So the question, what do I have? The question, how do I instill confidence with consumers in using, I'm looking at, in sharing personal and medical data? I would, in the first instance, I'd say, don't share it. Don't share it with a non-professional, right? If you're in an open environment and you're looking to use medical data, only use a trusted counterparty, but only have a yes, no. Don't expose your medical data, use a professional. That's really how I would answer that question. But the technology is there. It's come on in leaps and bounds. The security is built in. It's easily deployable. It's very simple. So the technology is there. And as I said, with ourselves and HealthX, we are leveraging a huge investment which the state has already made. This is a high trust environment on all aspects. So it's there already. So that's it, really. That would be my answer if that does.
Yeah, I want to invite, I know that data security is, is a big issue kind of across the industry when it comes to health tech platforms. I want to invite any other panelists to weigh in if you have additional thoughts on the challenges or opportunities here.
I'll only say one quick thing, and I didn't introduce myself before. I work at Medidata, which is, I think, arguably the largest healthcare IT company that's ever been founded in New York. And we do literally the majority of clinical trials in the world on our platform. I say that with no self-congratulations. We have a lot of other work that we need to do. But just to give you the sense that I just get to see a lot from what I do in terms of how people are digitally engaging. And I really think that tools for life sciences, and I think Ted and Brian are saying this in almost a perfect way, digital tools are the same as molecular tools and medical device tools, and that they can be used to help us practice medicine. These are the tools that we use to provide healthcare. And one of the interesting trends I've seen is companies who are building tools, whether it's medical devices or molecules, are starting to realize that these digital technologies, whether it's patient engagement, whether it's actually measurement of something from a diagnostic or from a disease progression perspective, that's got to be part of the delivery. And so these questions about cybersecurity and privacy are going to wind up being worked on. I don't have all the answers, but baked into the innovations that come out of the world of life sciences and come out of, obviously, the world of healthcare IT. But I just think there's reasons to be optimistic because of the value that they're going to bring, that we as individuals, as patients, all will figure out how to wrap our minds around some ground rules like what Brian was talking about, because we're going to want to get those benefits. We're going to want to have that contact tracing find us as quickly as possible. So it'll be a give and take like anything, but I'm very optimistic about the taking in a good way.
Dr. Long, I'm curious your reaction to that. Are people giving because you're providing a service? What's been the experience with the Test and Trace program on, soliciting people to share personal information?
Yeah, I mean, the principle behind it is trust. And I think, trust is multifactorial in terms of how you, and I use my words carefully here, earn it, and it must be earned. And I think as Glen and Brian were both saying, there's a component of earning trust that is, can you ensure that my information is going to be kept confidential and safe? That's really, really important. There's other components of trust too, and that's where in terms of, having the same lived life experience, being able to understand the person on the other end of the phone, those are all very important components of trust. And I think, we on the test and trace side have worked really, really hard. We started with listening. We've always been very confident in the security of the data that we collect. But it's one thing for me to be confident. It's another for me to be able to communicate to somebody that's being contact traced that this is a secure activity, that anything that they would share is going to be kept secure. So we actually have a lovely community advisory board, and we really listened, and all of the ways that they talked about how we should be communicating that the security of our data is how we've done that. And I think we've evolved over time. And part of your question is, how do we know if we've been successful? And I would say probably the most important data point that I look at day to day for that is if people are taking the time to complete their interviews with us. If you're a case, somebody recently died or newly diagnosed with COVID, and we call you, what percent of the time are you going all the way through the interview, meaning you're answering all of our questions, you trust us enough to share information, and you see enough value that you're not hanging up on us? This is a voluntary program, by the way. If I call you today, Sabrina, you could be on the phone with me for 2 minutes and then say, this is Ted, no, and you could get off the phone. Every week now, around 80%, sometimes more than 80% of every single person that's being diagnosed that has a positive test for COVID in New York City, 80% of the whole denominator is going all the way through our interview. Was that true on day one? Absolutely not. We've improved a lot over time, but I think it's looking at trust from all those different dimensions. And I would just emphasize my agreement that a very key dimension is being able to have us assure the person on the other end of the phone who is sometimes scared, cautious. I mean, they're being told they have the coronavirus. It's not a positive piece of news we're giving them there, but our ability to communicate that they can and should trust us and that their data will be kept secure. If that wasn't true, if we didn't earn their trust in that way, there's no world in which 80% of everybody with a positive test would be completing interviews today. I think we're doing a good job now of earning that trust, but it's definitely been a journey. We've done a lot of listening, and I take to heart the importance of it.
I appreciate that. I want to zoom out a little bit. We've talked a lot about kind of innovation specifically in healthcare delivery, but I think we could all agree that solving public health issues, and in fact, I think somebody said this early at the beginning, isn't just about healthcare services. It requires addressing broader social determinants of health. And Maryanne, I know this is something that you spend a lot of time looking at, and in fact, the center that you work in and the administration was founded by you in this administration in order to innovate with data intelligence to better tackle these larger social determinants of health. And I wonder if you could share with us a bit, what you hope to do differently with this center, how you hope to innovate from inside government, and how it's going, what you feel like you've been able to accomplish with the foundation of this office.
It's going really well. And I think that the mayor has done an amazing job of integrating the agencies and allowing all of us to work together in a way that has made a bigger impact than any one of us on our own could have made. And it's just really incredible. And I think that story will be told later, not as now in the political environment, but the collaborative process is astounding. And I've been very fortunate to have CIDI, which is a data analytical institute, if you will, specifically designed for health and human services, to work together and share data and be able to, frankly, inspire us by the data to change how we do our work. And we've been very fortunate to have the level of cooperation from all of the commissioners and to work with their staff to figure out what's the best strategy to resolve interagency issues. As folks have said on other panels, that people come into a door and they don't know that there's a separate agency or a separate place. And we want to be able to, whatever door you walk through, we resolve your issue or get to where you should resolve without having to go through all of these many steps that sometimes happens. So we've been able to have this amazing collaboration. And how, just to mention on data, a lot of people say to me, oh, data schmata, oh my God, there's so much data. And that is actually the truth. There's so much data. And what we try to do is take what's important out of the data and to put it into a document that is so easy for you to read so that you understand what the data is telling us. And that is, you would think that that would be easy to do. And that has been a huge challenge, to be able to say, what is it that our agencies are struggling with, or an agency is struggling with that has something to do with another agency as well. We talk about homeless and health and child welfare, and what are the interagency collaborations that need to happen in order to resolve some of these issues. And what we do is we form work teams and work groups. So we frankly get to the right question and make sure that the question we're asking is the one that'll lead us down the road to resolving the issue. And then we pull the data as to what would make sense to answer that question, where I think that has taken time to understand the importance of questions, frankly. Because there is, if you will, fire hydrants of water, of data coming at us at all times. And people can make correlations and can make stories about things that really don't matter. And we work with groups of people in our agency and people with lived experiences to say, what is the data that matters to you? And in some cases we collect it, in some cases we don't. But what our, if you will, our challenge is always to work with the agencies and to focus on things that will matter to them. And in our reports, we help to, frankly, help the agencies to respond to an emerging issue or an issue that has been a very tough, possibly intractable issue that's been going on since our grandmothers. And how are we going to resolve that? And I think that's what we are really good at doing, is bringing the agencies together and working together through the data and letting the data tell the story with an interpretation through other folks who have experienced that. I just want to mention too, it's interesting because it's only with Mayor de Blasio that health has been such a pivotal piece of all of this, where we used to focus mostly on human service data. And we would do a lot of work with child welfare, a lot of work with homeless. Now it's very rare that health is not involved, whether it's through Commissioner Katz at Health and Hospitals, or the commissioners at DOH, who we heard today about how the idea of working together and how we have an evolving approach. And that has really been what we do at CIDI, is we adopt and change, but we have created the protocols, and as the data security, the IRB, the institutional review boards, and to assure that the data that we're collecting is data that we will treat sensitively with people, for people, and by the people. And so that has been something, we often say, and we've learned because we work with a lot of youth too, nothing without us. If it's about us, you can't leave us out. And so that's the work that we do, is to be very integrated with the people that we're working with. We were very fortunate. We did a few reports on the community, we did a community atlas by a 2-generational approach. And much of that work was picked up during COVID because we were able to see different communities and the well-being of different communities. And so we've been able to put forth some of that work. And the same thing with our work with education and foster care and education with homeless services, to ensure that we can do the best we can in this environment to make sure that kids are going to school and getting Wi-Fi and access to education. So that's the work of CIDI and what we do and how we support our agencies.
Thank you for that. I'm going to springboard off that to, I think, talk about something that you're getting at when you talk about the interventions that you've been coordinating. And this question I'm going to direct it at Glen, but I think others on the panel probably have some thoughts about it. So I'll give Glen a chance to respond, and then if others want to engage a bit, I welcome that. And it's about health disparities, which is another topic we spent a lot of time, probably more time talking about in the last year, when we should have been spending a lot more time talking about it in years before that. But the last year really amplified issues around health disparities, differences in infection and death rates among different socioeconomic and demographic groups. In general, issues with access to healthcare during the lockdown, not just related to COVID infection specifically. So Glen, talk to us a little bit about how, if it's possible, some of the innovative approaches in healthcare could help address these issues of health disparities.
Yeah, so if you go back to what I was saying about life sciences, and you'll have to forgive or maybe appreciate, my view as somebody who really focuses on the tools for healthcare. So there's a very tool-centric view. But I really feel like we're seeing opportunities from an access perspective to use tools, including digital, very differently. And I'm very optimistic here that'll actually create a better environment that is much more equitable. Medidata, again, we have a really interesting view of the world. We long before COVID did a lot of work that's continuing around diversity in clinical trials. And the people who are in clinical trials are, and kudos to companies, including several who are working on vaccines for COVID-19, but they're largely affluent white people who live near academic medical centers. And it's because of this problem of access. Judy Dunn, who's a pharmaceutical executive and a great friend who lives in New York, such a New Yorker as well. We've been talking about that. Like in New York City, we could put anybody on a train and get anybody whatever care we'd want to give them. Yet even when the care is free, in a clinical trial, we don't see a representative demographic of the population. Why? And I think as you look at the tool makers, and that's inclusive of, again, people who are making molecules, people who are making medical devices, people who are making digital therapies, and you think about the shared unfortunate experience we all had of either the hospital's full, or I don't even want to go into the clinic because I'm scared, or I shouldn't go because I'm immunocompromised. We have all these people, including New Yorkers, who didn't get checkups and have undiagnosed conditions, who should have been actively managing their chronic conditions, and they've gotten worse in the last year plus, who had to pause their therapies and didn't receive what were going to be life-saving treatments. because they couldn't go to a clinic and get an infusion. All these things have to do with, again, some of these ideas that you had to put the caregiver and the patient in the same room. And thankfully, the economic and the ethical incentives of the tool makers for healthcare are usually very aligned in at least this arena. Because if I can help you some level of digital engagement, some level of mechanical delivery that lessens or takes away the requirement for a healthcare provider to administer a piece of the therapy, I take this problem of physical proximity and I start to maybe not make it entirely go away, but kind of turn the dial down on that. Meanwhile, I've increased the population of people out there who, if I'm a life sciences company, can actually receive my therapy in one way or another. And so I really think this is also part of that genie that's not going back in the bottle. And again, I'm never going to say silver lining about COVID, but there was this catalyst that is now getting people to realize that they have to think about access in the way they're designing the tools. How do I make sure I can get this tool to people who need it? If you told me a year and a half ago that there was going to be things on the cover of newspapers about the shipping temperatures of different pharmaceutical products and how important that is, I would have fallen off my chair laughing and been like I am about many things, super wrong. And so I think that again, I'm using the tool perspective, but whatever systems, whatever processes we're making around healthcare, we think about access first, we'll start to see much better outcomes. And we all had the shared experience of seeing how much disparity there is, even in our little city.
Yeah, Glenn, I just wanted to add to that because I completely agree, and when you think about the disparities, I think bridging that healthcare digital divide is truly that first step in fostering greater health equity, right? So how do we go in there and digitize all these workflows that you were just talking about, especially when you're looking at trying to find patients that meet the criteria, the inclusion-exclusion criteria for your clinical trials? And then how do you get those patients on those studies? How do you keep those patients on those studies? And I think that's where the innovation aspect comes into it, right? How do you take innovation and technology to digitize these processes and then take the care to the patient? How can we leverage, broadband, high-speed 5G connectivity and technology, leveraging drones? So you have a patient that's on a clinical trial, they're too sick to come in. Maybe you need to get them some medication. Let's have a drone equipped with that medication, goes to that patient's, front door, delivers them their medication. I used to be in the research domain as well, Glenn. So when you talk clinical trials, you're talking my language. I worked life science space for a while, and, finding those patients and, digitizing that process and how do we push care out to patients? And, I think that's where we come into play when we think innovation and technology, taking internet cafes out to these areas where they're underserved patient populations. We're very committed to providing connectivity. You were talking about, Maryanne, about, the children from the education, doing home-based school. How do we bridge that gap and address the homework gap regarding, limited access to internet? T-Mobile's passionate about this, and this is what gets me animated. And I start talking about innovation and technology and how we truly can digitize processes. And just when you think about one of the projects that I'm really proud of that we did at T-Mobile was Project 10 Million, providing access to children so they do have broadband coverage in their home when they typically don't, providing that to them free. Just in New York alone, we have connected over 300,000 students, providing free internet broadband coverage so they can do home learning. So yeah, I agree, Glenn. We need to look at digitizing processes, leveraging high-speed broadband and innovation, and push care out to the community.
If I may, it's another piece of the puzzle here in that part of what you have to do here, when going back to Cures Act again, what we're talking here is the patient's data, and it's their data, right? And they need to have access to it. And when I say control, it's the control to share or use that or give consent for access to that to another party. Where technology has moved in the last 14 months, which is wonderful, is the ability to biometrically attach someone to their file. And that means if you go through a portal like our own into HealthX, it means that the patient, rather than having to go through or directly through a participant, controls their own records and can give informed consent, and I'm thinking T-Mobile here, can give informed consent on the hoof, really, to a professional they want to deal with. Equally, from the trials point of view again, rather than having to work through maybe a formal organization, right? Because they own their own files, it's quite easy to build in adverse reaction reporting to a port like this, because you know that the individual who's responding to it is the individual attached to that file. You can anonymize it if you want, right? So equally, you can respect the privacy and security aspects that the patient needs. But then again, that has to be done within a high trust environment. Again, it has to be, to a certain extent, it has to be controlled. We're subject, as a business associate of HealthX, we're subject to all the HIPAA requirements on the data in there, front and back. So although there are wonderful opportunities, which I think will help everyone, we also have to, at the same time, keep in mind that you need to respect those boundaries as well. So it can't become the Wild West either. But I think it's a great, exciting time. And I won't say a silver lining on a cloud, but there have been great innovations and people saying, we have to make solutions, right? It's a new world. The talk of the idea that we could have had a vaccine 14 months ago, if anyone would have believed that from flash to bang, I mean, there's huge populations are being vaccinated now. It's unbelievable. It's unbelievable. And everyone in many ways should be, it's a fantastic achievement and should reinstill the faith and belief in science, you know, what it can achieve. You know, it's a wonderful thing. So I think it's very exciting times, and hopefully good will come out of this. We look back and say, you know what, it was a turning point. There were so many things that we developed from adversity. So that's my
Yeah,
view.
I agree with you, Brian, and I like how you're ending on such a positive note. And I think, you know, the same thing, there were so many interventions that were underutilized that we're now seeing more utilized, right? And one thing when I think about, you know, health equity and social determinants and IT connectivity, are the screening tools that healthcare providers are now using when patients present and they're asking social service questions. Do you have housing? Do you have food? Do you have transportation? And I think, you know, that was happening before COVID. I think, you know, we saw the immense need of those tools during COVID, and I'm certainly, you know, positive that those will continue. And Maryanne, it sounds like, you know, that aligns with a lot of the work that you're doing as well.
We've been trying to think that through for years to get them to ask 2 more questions. And it's always tough in emergency departments to, you've got your hands full, say, hey, do you need, what's your housing situation like? And we've done a few studies to indicate who we can prevent to become homeless in emergency departments so that we can intervene earlier and do some preventative work. So right on, that's exactly the thinking that we have around that.
Well, I feel like that is a lovely way to end this panel. I want to just thank you all for your time and your thoughtfulness, and I think we're all excited to watch where your programs and your companies go next. In I guess to Glen's point, advancing some of the things that may have been swirling for a while, but are finally really catching fire, and there's significant uptake for better public health outcomes. So I will say thank you and pass it back to Jeff.
Thank you so much, Sabrina, and thank you to all of you who have joined this Zoom today. I do, of course, want to thank our sponsors one more time. That's the Ostroff Associates, the New York State Conference of Blue Cross and Blue Shield Plans, Hinman Straub, CVS Health, Amita Care, Primary Care Development Corporation, Somos, Healthix, Healthcare Partners IPA, Emblem Health, Brown and Weinrob, T-Mobile, Medidata, and Health First. Thank you so much to our sponsors. And hey, if all of you liked this event, would highly recommend that you join for some future events. If you have any connections to Rochester, we're hosting an event tomorrow, Friday at 10 a.m., a AARP sponsored series focusing on the Rochester region and the ongoing COVID response there. Registration is free. You can look for it in the chat. Also check the chat for details on our last installment of the coronavirus update series, focused on safety, and that's in coordination with the Office of the council to the mayor of New York City. That's been a really cool and very interesting look into the mayor's office. So tune in next Thursday, 2 p.m., more details in the chat. And on Wednesday, April 28th, for any of you in the nonprofit sector, we're having a New York Nonprofit Media 40 Under 40 event. That should be fun. We're having a power panel of nonprofit industry heads, and we're going to be toasting some real leaders in the nonprofit industry. And with that, I want to thank all of you for watching, and especially thank you to our panelists for joining, for hosting this virtual Healthy New York Summit with City and State. And we hope to see you at our next health event. And hey, hopefully it'll be in person. Thank you.